right. Hello, everybody. Welcome to SOAR's COVID and Cancer Series, Episode 3. I'm Hannah Kim, the CMO of SOAR.
Hi, I'm Claire Q, the medical liaison. The series was created to talk about the issues surrounding COVID-19 and its effects on the cancer community through different conversations and encourage everyone watching to donate to help us combat the economic effects of COVID at donorbox.org/SOAR above. And we're just talking with different oncologists, survivors, nurses, etc. about their experiences through the pandemic.
All of the donations we receive up until August 15th will go directly to the Greater Houston COVID-19 Recovery Fund to aid those in need of food assistance, affordable childcare, and basic financial hardship caused by COVID-19. Today's guest is Dr. Girija Anand, a consultant in clinical oncology at the North Middlesex University Hospital NHS Trust in the UK. Hi, can you briefly introduce yourself and why you decided to go into the field of medicine, specifically oncology?
Well, first of all, thank you for having me. I'm, as you've just said, Dr. Girija Anand. I'm a consultant clinical oncologist. I work in North London. Majority of my work is in the public sector, so you may have heard of the National Health Service, NHS, and I do some private work as well. A clinical oncologist in the UK is equivalent to a radiation oncologist in America, but in the UK, we also oversee chemotherapy and targeted treatments. My interests are service development, teaching, and research. I'm also a faculty member of the Royal College of Radiologists. I became an oncologist as I knew in my heart I was a physician, not a surgeon. And during my postgraduate training, which I think you call residency in America, I rotated through various medical specialties, and one of them was oncology. It was here that I found my passion. What I liked about oncology as a career was the ability to be able to see patients throughout their whole treatment pathway, so from diagnosis to treatment to follow-up. And during that period of time, you develop a real rapport with patients and their families, and I really liked that. That really resonated with me. Also, the specialty of oncology, it's a very fast-changing field with research, new drugs, new technology, and it's really revolutionized how we treat cancer. I mean, so much has changed in the last 15, 16 years since I've practiced oncology. So it makes it really interesting and exciting to be at the forefront of delivering practice-changing medicine. I think radiation oncology is also an interesting field for those of you who've got an artistic interest, as radiotherapy planning is essentially precision drawing around anatomical structures. That's my favorite bit of the day.
That sounds really interesting. Can I ask what a consultant is in terms of clinical oncology?
So a consultant is the most senior person in the team. So like, I think it's your attending in America. Is that right? That's the most senior person. And, you know, you can obviously have different things that the consultants do. They do other leadership roles like clinical director or go into management, but it is the most senior doctor in the team.
Okay, that makes sense. So has your hospital admitted large amounts of COVID patients, and were you switched to health COVID units?
Yeah, so my hospital was particularly affected. We're in a geographical area where we had a high prevalence of coronavirus and a very high number of cases who had very serious infection. There was at one point, particularly around March, April, where we had every single ward filled with COVID cases except one ward. So yes, we were quite severely affected where I work.
What kind of physical precautions have the hospitals that you worked at adopted during the pandemic?
So we've done, you know, things for patients and stuff for staff. So for patients within our region, we worked really closely with the private hospitals to create clean sites for essential elective cancer surgery so that that could continue, because patients still need to have their cancer treated. And all patients who were screened for operations were screened for COVID, and they had to self-isolate pre and post procedure. This was a really effective collaboration with the private sector. In fact, the NHS bought up all the private hospitals during that peak time. Many hospitals had a high number of COVID cases, had to think quickly about how they delivered cancer care to patients safely. So we worked with local charities. In my particular hospital, from charitable donation, we were able to get 2 chemo buses. So they were parked in the main hospital car park. So patients didn't have to come into the main hospital for their treatment. We also developed drive-through blood testing, so they again didn't need to come into the main hospital for treatment, for diagnosis. And also diagnostic imaging was done off-site on what we call clean scanners, to reduce the risk of cross-infection. And we had to COVID symptom screen for all our patients and carers. For staff, we adopted lots of new ways of working with remote consultations, remote access to hospital systems. So even those self-isolating could continue to work from home if they felt well. And all of these interventions ensured less exposure to the virus. We also had to work with local businesses because, as you know, there was a global shortage of PPE, so we managed to get donations for visors and gowns, and all of that helped in sort of infection control and protecting patients and staff.
So I know you talked about a lot of these precautions that your hospital has adopted. Were there any additional increases of sanitary/disinfectant preparation once COVID started?
Yes, of course. All clinical areas are now cleaned much more thoroughly than before, which is good. And especially after each patient is seen, whether the patient has COVID or not. If the patient is known to have COVID, then it's more deep cleaning, which takes a longer period of time. My particular hospital, now that we're out at the peak, so when I'm talking about the peak, it was around end of March, beginning of April, where we had, unfortunately, over 1,000 deaths a day. But now we're down sort of low 20s, teens at the moment. And so we're trying to prevent another peak. So again, as I said before, where we are geographically located, there's a high risk of more COVID cases and having a second surge. So our hospital's planning to divide itself into 2 areas. So we've got a blue zone and a green zone, and the blue zone is a COVID managed zone. So anybody could potentially have COVID. And the green zone is the COVID protected zone. So that's where I work in oncology, where we absolutely minimize the footfall through the department, do as much remote consultations, and really screen patients and ask them to self-isolate pre and post treatments or any procedure.
So you kind of talked about the shortage of the PPE that you had at your hospital, but are you satisfied with the PPE that you have right now and other medical instruments provided that help prevent spreading of the virus at your hospital?
Yes, I think so. I think now we're okay. There was a global shortage of PPE. It wasn't unique to this country or my hospital. And I think at the beginning, you know, the PPE people who needed it most, which was the front line with the kids, had to prioritise. It was much more difficult for us in those who are in non-acute specialties, like in cancer. So a lot of us just switched from our usual formal suits to hospital scrubs. I talked about charities donating visors and gowns. So all of that helped. And the whole idea was to ensure that we reduce the risk of cross-infection, and the R rate should be less than 1. Do you know about the R rate? Have you heard about that? No. Okay, so the R rate is the ability of the virus to reproduce and spread the disease. And it depends on how contagious the disease is. So something like measles has an R rate of 12. So for every 1 person infected, they can spread it to about 12 or 13 people. For COVID-19, the coronavirus, the R rate is 3, believed to be 3. And the whole principle about managing infection control for governments is to keep that R value less than 1. And at the moment in the UK, we are less than 1. But as soon as it surges beyond 1, then they might start to do local lockdowns, which I think is something you're experiencing in America as well, isn't it? Depending on the number of cases.
Yeah. So, do you know if COVID-19 has affected any cancer treatments and research done in your hospital or other areas?
Yeah, so what was amazing during that very difficult, stressful time for everyone was over a weekend when we had this sudden rise in cases. I mean, it hit us. We had national experts across the whole country in cancer who were writing national guidelines over a weekend. I mean, national guidelines usually take months to publish. This was like written over a weekend to help clinicians who are seeing cancer patients, to help them triage their treatments based on priority, based on the efficacy of the different drugs for each tumor site. And there was excellent communication and engagement amongst clinicians via the Royal College websites to support colleagues and pathways. Our oncology service was able to maintain some activity in a variety of ways. And we did this by adapting new ways of working to maintain the throughput for patients. We also had a reduced workforce due to sickness and people needing to self-isolate. It was a really busy time because we had to have very difficult conversations with patients about prioritizing treatments based on these new national guidelines. Some of it involved stopping patients altogether because they were high risk in the vulnerable groups. So if they developed the infection, their risk of dying from COVID-19 was really high. I think there was a study from China which suggested a 30% mortality from COVID for cancer patients. So we were really keen to protect the vulnerable ones. And clinical trials during the time was put on hold for about 3 months, and I think it was the right thing to do. We're now in the recovery phase. As I said, the number of cases have come down, so we're slowly starting to open up trials over the next few weeks.
Do you think that hospitals will be impacted in the long run due to the pandemic?
I think that's a very good question. I think it's difficult to know, and time will tell. What was interesting at our particular hospital, I can't speak for the whole country, we were able to maintain our cancer activity, but we did so from the reasons I just described to you. We also, all treatment regimes take safer, give more important drugs, lowering of the immunity. We also reduce radiotherapy treatment. So radiotherapy is a course of treatment that's delivered over many days, and we used regimes which delivered the same treatment but over shorter times, to reducing visits to hospital. So I think, as I said, we maintained activity. What we have done nationally is what we call a harm review database, and all hospitals, particularly for radiotherapy, have signed up to it. So we're collecting data to see how the change in these treatment regimes, if it's harmed patients in any way, or if we'd had to stop, how will that impact on them long term? I can't really say at the moment. Time will tell. One of the bigger concerns is delays in diagnosis, because a lot of the diagnostic stuff had to stop. And so we are seeing some late presentations of cancer. Patients coming through A&E or ED, and they've got very advanced disease, whereas normally you would pick them up earlier in the pathway. So I think we do have concerns that there will be a higher death rate from cancer in the next few months, but it's difficult to know at the moment.
How has COVID affected you in your personal life?
So what do you mean by that? Is that me personally at home, or wasn't sure?
Yeah, that works too. Like, how have you changed your lifestyle?
Okay, so well, I got the virus probably through work, as most of us did at the time. Luckily, it was a mild infection. I managed home and recovered, fully recovered. It's impacted just like it has the rest of the world. You know, my kids have had to be homeschooled, which has been challenging. With, you know, still had to work, and still, and I know lots of other people have had similar issues. Shopping became an issue. I'm sure, I don't know what happened in America, but when peak hit, we didn't have a lot of notice when it just arrived. There was a lot of bulk buying, and it was really challenging for what we call key workers in this country. So people who had to go to work, we'd go to the shops at the end of the day and there'd be no food, everything had been bought out. So that was quite challenging, but then the government introduced priority shopping for key workers, so that made life a bit easier. Yeah, so I think the remote working has been quite good. You know, a lot of the meetings that I'd have to travel to, I don't need to do anymore. We do it all remotely, and I think that's helped with work-life balance. So yes, I think there have been, amongst all the difficulties, there have been a few positive changes in terms of a bit more remote working, and, you know, reduced waiting times for patients as well.
So I guess before you started doing your remote work and before you contracted the virus, how did you protect your family when you returned from work, and how do you suggest others protect themselves and their families?
So my cancer patients ask me this all the time, particularly as of next month, which is just a few days away. The government's going to ease the rules even more, and people who are vulnerable can come out as shielding. What I personally did is I started wearing scrubs. I bought my own pair, pairs, a few of them. Again, they were difficult to get hold of, but managed to get them in a few weeks. I changed my very formal work bag to a washable rucksack so I could stick it in the washing machine. I wore the same pair of shoes. So I had a pair of shoes I wore to work, and then I changed into a pair of shoes that I left at work. I never brought them home. As soon as I got home, I'd leave all my stuff in the porch, never brought it into the house, and I'd go straight for a shower, and I'd stick everything in the washing machine, and you have to wash it at 60 degrees because the virus can survive a 40-degree wash. So everything has to be washed at 60 degrees, and just practicing really good infection control. So we talked about that R rate, the ability of the virus to replicate. So it's social distancing, wearing a surgical mask. Now at work, because they don't want to have another rise of infections, we all have to wear masks at work. We change that every 4 hours, lots of hand washing, and really just making sure that you only sort of interact with people if you absolutely have to.
Mm-hmm. So this is 60 degrees Celsius, right?
Yes, that's right. Yes. It's Fahrenheit, don't you?
Yeah. Also, I know we didn't send this to you, but can you elaborate on your experiences as when you contracted COVID and how it felt?
Yeah, so it was very weird. I didn't have any of the typical symptoms, the first 3 symptoms, which was initially in the guidelines. I know that's all changed now, which was fever, dry cough, and shortness of breath. I didn't have any of those. I started off with a really bad headache, feeling dizzy, and a bit of a sore throat. And I was just lucky it was at the end of the week. So I called, you know, work, and I said, look, I'm going to work from home. I'm not sure if I'm coming down with something, but I just, you know, just to be safe. And then a couple of days later, I became more unwell, just really tired, sleeping a lot, had a bit of nausea, had a bit of diarrhea. I had one day where I had a bit of a cough and shortness of breath. But it's really funny with the breathlessness because it plays on your mind. I've got a bit of asthma as well. So the more you think about breathlessness, the more breathless you get. So it was trying to distract myself. So I actually decided to do a clinic on the day I was breathless, but actually it was a good idea because it was all from home. So it was telephone consultations. I was helping people at work. I talked about remote working, and it actually distracted me. And I realized that my breathlessness was just in my mind. But I think the most profound symptom that we know now is one of the main symptoms of the virus is my loss of smell. I had loss of smell, loss of appetite, and extreme tiredness, and that lasted for a good week. My husband also caught it, but his was a bit more severe. He had a bit of a cough and a bit of breathlessness too. So I think it's what is very different about this virus is how it affects people very differently. And it's so unpredictable about who will get the severity of the illness and who won't. I mean, we do know that there's certain groups of people who are more risk than others, but even then you can have very fit young people who get a very severe infection and sometimes unfortunately die of it. And you can have people with all the listed potential risks of getting a severe illness who are absolutely fine. So it's very unpredictable, and that's why we all have to be extra careful.
So how do you think your experience in the UK differs from what we know in the US, or what we've been doing in the US?
Well, the UK did have a particularly high death rate compared to the rest of Europe. I think we've had just under 44,000 deaths. I think in the US, you're sort of just under 130,000 deaths, sort of late 120s. But you're a bigger country. And in the NHS, we had to adapt as for all the things that I've said before. Our government did build a hospital called the Nightingale Hospital in London, because London and Birmingham were two of the places that were initially severely affected. And that was to house 4,000 critical care beds, but actually we didn't need to use it that much. I think in the end, they only treated 50 patients. I mean, at its worst, we had, which was around the first week of April, we had about 1,000 deaths per day. I think the COVID-19 disease is treated very differently in the UK compared to America. My sister-in-law is an infectious disease consultant. She works around sort of Bucks County area. And so we were texting each other, and I think there was a lot of use of chloroquine and one of the anti-HIV drugs, remdesivir. In this country, we were not allowed to use anything outside of a clinical trial, and we had a big national trial called the Recovery Trial, which we recruited. Our particular hospital was a big recruiter for it, and it was from that study that we found out that steroids actually can be quite beneficial for patients who need oxygen or ventilation. And actually chloroquine, which was the anti-malarial drug, was shown to be detrimental in an American study. So I think it was practicing of more evidence-based medicine in the UK compared to America. But I think it's very difficult because, when you're faced with a deadly disease, people will want to try anything, and it's quite hard. And we didn't have all the evidence that we have now. And, not using chloroquine and not using some of the things that they were using in other countries was quite hard to explain to patients. So I think that was a big difference. Also in the UK, they recorded deaths in care homes, so where elderly people were, and I'm not sure how much the rest of the world has done that, because we know that the recording of deaths is very different around the world. And we found in the UK we have such a high number because we also included deaths from care homes, and they also struggled initially because of the global shortage of PPE to have enough PPE to protect their residents. Now all of this has improved, but I think those would probably be the key differences. I mean, I haven't been in America, I don't know how it's managed day to day, but I think those are probably the big differences.
Mm-hmm. Yeah.
Speaking of trying new things to try to prevent the virus, we've heard of the term herd immunity used to describe the efforts the UK government has taken against COVID. Can you explain what this means and what the results were?
Yeah, sure. So the principle of herd immunity is to allow the infection to spread over a longer period of time. So it's to avoid peaks like we had back in April, and to just flatten the curve so the health system can cope and doesn't get overwhelmed, particularly as there's no cure and there's no vaccine yet. The idea is to protect the vulnerable and the elderly, who are most likely to get a severer infection. And if enough of the population gets the immunity, it prevents spread. So it reduces that R value that I talked about earlier. So in the UK, our population's around 60 million, and they've estimated for this particular disease, 60% would need to get immunity to reduce spread. But so that's about 40 million. And we, as I said before, even though we have high risk groups that get severe disease, equally in that 40 million, there will be people who are fit and well who will get severe disease as well. So there was a big risk in sort of using herd immunity as a policy. And I think the government did take a U-turn on this back in May, because of the risk to unexpected individuals.
Yeah, makes sense. You mentioned previously that the NHS has been taking over private hospitals and things like that. Are there other aspects of NHS funding that COVID has affected?
So when the lockdown was announced, which was towards the end of March, the Chancellor then also said there would be additional funding committed to COVID. And I think they released about 14 billion. And of that, about 6.5 billion went to the NHS. So a lot of that was put into technology, improving infection control, PPE, to allow us to do our jobs, to building the new hospital that I talked about with more critical care beds. So yes, so additional money has been spent. How that's going to affect the economy long term, we'll have to wait and see.
All right, thank you so much for participating in our online series. We really appreciate you taking the time out of your day and your busy schedule to have this interview with us.
And thanks to everyone who tuned into today's episode. We hope to see you all next week.